So, good evening, all. Today's topic is unmet nutritional needs in hospitalized CKD patients. Not just CKD, maybe AKI on CKD, AKD, and others. So, just basically to go through. So, a CKD can be a stable CKD. That means the patient is already having chronic kidney disease for a long duration of time. It is pretty stable, going on medications, and then he gets hospitalized for various reasons. It can be even for a fracture, it can be because of fever, it can be because of COVID, or it can be because of pneumonia requiring ICU care, right? So, any of these particular encompassing the requirement of hospitalizations we will be dealing with. So we will be talking only about the nutritional care in these particular cases. So we will also be dealing with a patient who is having a CKD and lands up with acute kidney injury. Obviously, whenever a boxer has a fracture, he goes and does some more boxing, obviously the fracture worsens. So the same situation, whenever there is some particular infection or there is any other problem, obviously there is an acute worsening of the kidney disease. So that is called acute kidney injury. It can happen either directly when the normal kidneys are there or when there is a CKD. So when the CKD is there, obviously the damage is much more. So that is called acute kidney injury, and it happens over a period of few hours to days. Whenever it is happening beyond a few days to a matter of 3 months, then it is called acute kidney disease or AKD. Okay, it's just terminology just for us to understand basic various etiologies. So now when we go ahead with a CKD on AKI on CKD, it's obviously the damage has occurred on a patient who is already having CKD. AKD alone means when there is an underlying normal kidney disease with an acute kidney injury, which matters over days to 3 months, and when there is an acute kidney injury alone over a matter of few days. So it has happened on either a normal kidney or on CKD, right? So when we talk about CKD, all these patients are the ones who are not requiring dialysis, right? Because these are the patients who are having a kidney disease, however they have not yet landed on the stage of dialysis. So an acute kidney injury can push them towards the stage of dialysis, or a person who is already on dialysis, like a patient who is undergoing dialysis on regular basis, maintenance hemodialysis, comes down with some problems like a pulmonary edema or a fever or breathlessness. So that particular patient who is getting admitted, obviously those people will be requiring the further care, right? So this entity is basically where CKD with renal replacement. Here we can also call it as kidney failure. So actual kidney failure is this, where they are requiring dialysis, not when they have a chronic kidney disease. Okay, otherwise if you talk about failure, then it's a term which really scares anybody. So don't talk about a kidney disease as a failure. Failure is only when they are requiring dialysis. That means the kidney function has gone down to less than 10% and they are requiring dialysis. So now in hospitalized individuals, so what is the basic problem in all these kidney disease patients? We all know that they're all having multiple other problems. So a person can be having diabetes, they can be having hypertension, they can be having ischemic heart disease, they can also have cancers which have led to the renal dysfunction. They can have hepatorenal state where they'll be having cirrhosis and they'll be having this renal involvement. So when multiple problems are there, that means it is multi-speciality case, right? So multiple people have to get involved to take care of the patient. So it's not just kidney, it is basically encompassing the patient as a whole. So always look at renal failure as a patient whose kidney is not working well. So it's basically a physician who is taking care of a patient whose kidney is not working well. That is what is a nephrologist. So nephrologist doesn't deal only with the kidney. He is dealing with a patient whose kidney is not working, right? So we are basically physicians finally, right? So that is how we need to start looking at things. So you have to encompass involving all people. If there is an orthopedic requirement, obviously an orthopedician comes in, but orthopedicians love giving painkillers, right? So is it good for kidney? No, it is not good. But we have to give something for pain relief. So we need to remember that. So we have to give something else to give a pain relief. So that way the specialties will encompass all sorts of problems whenever there is a kidney disease. So in multiple comorbidities with inflammatory processes going on. Why inflammatory process? Because CKD itself is an inflammatory state. Okay, any kidney disease will lead to inflammation at various levels. It can be in the vascular area, it can be in the brain, it can be in the heart, it can be in the lungs. So the inflammation is an ongoing process always. So if you just check a CRP for a patient who is having chronic kidney disease, inflammation will be seen. So it is a very non-specific entity. Okay, there are very few patients who are stable without inflammation, right? And these inflammatory markers will start increasing once the patient is requiring hospitalization. So once the inflammation starts in, then that fellow is going downhill. So we need to have a way of bringing him back, so to the physiology of his before, right? So ICU always, the requirement can be either off and on. That means that the patient is come in and he is in the ward, but suddenly he can deteriorate, requiring an ICU stay, right? These kind of entities can usually be seen in chronic kidney disease patients who have multiple problems, like an ischemic heart disease or a low ejection fraction. So these particular patients will suddenly be required to be moved into this ICUs. But whatever else we can think of is when there is dyselectrolytemia, like say for example there is hyponatremia, hypokalemia, those people also will be requiring ICU care. Here it is a different kind of a presentation where it is not in the normal setting, like an acute hyponatremia patients are usually having coma or encephalopathy. So they are shifted into the ICU, given 3% saline and then managed. But a CKD patient cannot be managed in the same way because 3% saline will cause fluid overload for these patients, and we cannot deal with them in the same manner. So we need to identify what is the cause of hyponatremia in them and then treat. So we need to look at all these particular factors when we are moving a patient into the ICU. So the most important is dietary restrictions. So we all restrict patients for various diets, right? We tell don't eat this, don't eat that, don't eat this, don't eat that, don't that you have to minimize, and this you have to not allowed. So finally what are they eating? Nothing, right? So by the time that fellow comes to us, if he is a stable CKD eating all right, he will still be malnourished. So once you get into the hospital, that fellow's nutrition status goes down further. So that is what we need to remember always, right? So this I just thought we will bring up in general about the dietary habits in India. Why I am talking is, I may look obese, but I may still be malnourished. Right? Agree? Not agree? Yes. So why? Because you see the various vegetables. So here you can see that the vegetables, fruits, legumes, animal source proteins, wherever there is darkness, that basically indicates that all these areas, they do not even take it in proper proportions. So they lack very much. So if you see overall in whole of India, we do not fall into that category at all. So what we are taking is actually not a balanced diet. We'll be using lesser things even in various other modalities. Like it's not just about rich and poor. Rich fellow will be eating only burgers. So that means he's eating saturated fat and only processed food. But where are the vegetables in there? Don't tell me that lettuce is a vegetable in that leaf. No, it is not. It's not. So if we need to look at all those particular factors. So if you see in normal individual who is not having CKD, about us I am talking about. So if we do not have CKD, this is the state of affairs. So just imagine when they are having CKD then. So obviously we are dealing with multiple problems. So we are going to stop everything here. So we don't give canned food, we give lower potassium diet, we give low salt diet. We tell them not to take too much of fat. We tell them to cut down on green leafy vegetables. We tell them to cut down on nuts. We tell them to cut down on dry fruits. So finally, what is the diet they are taking? Cereals. They are eating rice or wheat. That's it, or jowar. Other than that, they are not taking anything. So finally, the requirement for them is much more. So they are usually malnourished. So the older days thought process was even more worse. They never used to allow even pulses. So our professors, when I was learning, they never even used to allow them to eat dal. Dal was allowed once a week. That was like a celebration, like, you go and eat biryani on Sundays. So like that, it used to be a celebration. Now, of course, you eat biryani every day and maybe eat curd rice on once a week. So, right, so this is the problem which we have been looking at, right? So we have to have an understanding what we are also treating them with and what we are giving them a diet for. So a CKD in general doesn't require restriction of too many nutritional values, right? What we are talking about is a CKD. It's not failure, right? So if the person is not having dyselectrolytemia, like say for example he doesn't have hyperkalemia, then why are we restricting potassium containing foods? If he does not have hypertension, then why restrict salt? So we need to look at all the things and moderate it. The problem with Indian diet is, see, first thing is our environment. We need to understand that we sweat a lot more than people who are in the temperate zone or the higher up. So in such a situation, those people are anyway losing salts. First thing, let me be clear, sweat is not salt rich. Okay, only for a few people it is salt rich. It's mainly water loss, but it also contains electrolytes. Okay, so that is why when a marathon runner faints, do not give him water. Understood? So same thing when we are having a CKD patient, when we are not giving him any salts, okay, then what happens? Obviously these people go into hyponatremia. So we need to look at those particular factors and maintain the vitals for them in a very smart manner. It's very important for us to understand these particular entities. And DASH diet, all of you know about DASH diet, right? So when we have to dash it in CKD, why we need to dash it? Because hyperkalemia will occur, right, if you keep giving them fruits. So, and fruits are to be given in moderation, not to be given in excess. So the fruits obviously which are low potassium containing are very few. Okay. So when we are giving so much of fruit intake in these particular patients, we have to also understand that lot of fads have come in. Himalayan pink salt, right? It is the best salt on earth now. So that is the problem when we have it. So when it is advertised like that, people start taking Himalayan pink salt. I have had tough time fighting with them saying that don't take pink salt because it is causing hyperkalemia for you. Right? So we need to remember that. So low sodium salts, Lona salt, okay, or Tata Light, all these are not good salts in CKD. Okay, and along with that, don't use the Kallupu. Kallupu is basically which is not ground, it is not a refined form of salt. That is the common salt which is used in the rural areas, right? The problem with that is because it is unrefined, it can contain potassium, it can contain calcium, it can contain magnesium, and it can contain other materials. So we need to remember that a refined salt is what is required in CKD, and an unrefined salt is okay when the kidney function is normal but that person has hypertension. So there is a difference in the way we need to deal with them. So a patient who is having hypertension goes to CKD, we need to change the salt. Okay, so we need to remember those. So that is what is the problems which we will be facing in them. And because we have our own social mentalities, because here we are taught like that, our grandmother used to use this, so I am also going to use this. Because no book specifies Indian diet. No book specifies. Whatever diet we have got from the Indian data is the one which is giving. And we have not really sat and calculated what I require, what we all require. Why our diet is a bad diet? The problem is our diet is not bad. We are bad. We are not doing our exercise. We are not doing our physical activity. That is the problem. We were always farmers. We are no more farmers. So we are using only brain. So because of that, your carbohydrate rich diet which was being utilized for the high energy purposes in a tropical climate is no more good. That is what needs to be understood. That's why you need to change over to use of vegetables, use of dal. So that particular entity holds good even for a CKD, right? So CKD and protein energy wasting. Now we have caused some problems. CKD also causes problems for the patient. Why? Because it basically causes problems in the sense that it is a hypercatabolic state. That is why I was telling you there is inflammation. So when there is hypercatabolic states, the protein which is taken in is not absorbed, carbohydrate taken in is not properly absorbed, or if it is absorbed, the insulin resistance is there and hence not utilized properly, and there is also lipolysis problems. So because of that, the carbohydrates gets converted into fat and it is deposited at abnormal places, and vascular calcifications start occurring in CKDs, right? So these are the problems which we will be facing and which is worsened by metabolic acidosis. Once there is acidosis, there will be chelation of the bones and hypercalcemia will be seen, hyperphosphatemia will be seen. Why that is seen is because calcium is first of all low in CKD patients. So to maintain the calcium levels, it starts chelating from the bone. So the bone deposits of calcium is less. So they are not doing fine, and also the muscle mass comes down. So the patients will be having sarcopenia. So the muscle, that fellow looks all right, okay, but he is having sarcopenia. So this is called obesity sarcopenia syndromes. So they do not do well, and also frailty. Once these particular nutritions go beyond one particular level and the particular physical activity starts coming down, and these people do not have intake because physical activity is low, they are not hungry, and also they have other problems like diabetes causing gastroparesis, diabetes causing neuropathy, their appetite is very poor, then there is fluid all over. So once there is ascites, fluid overload state, then they will not be feeling hungry. So all these particular matters will cause malnutrition. So all these factors also play a role in just CKD when they are not even admitted. So just imagine once they go in for admissions. So these are the things which we need to look into. And once they are on dialysis, then it is a matter of we have to replace more. So we need to start giving them more protein rather than what they used to take when they are having CKD with non-dialysis requirement, right? So this is what we are talking about. So obese people doesn't mean that that fellow is fine. Even he can have multiple problems and that fellow also will be frail. So obese people need not be always doing well. But yes, there have been studies that obese people do better than the frail people in dialysis. So that is how it is being seen, right? So now negative effects on nutrition because of all these. So we have already seen that peripheral insulin resistance is there, there is reduction in lipolysis, there is antioxidant system depletion, then pro-inflammatory state. So the pro-inflammatory state is not only because of the CKD or the AKI or AKD which is there now, but also because of the disease process. So there is sepsis, there is infection, there is inflammation. So all those phenomenon also lead to worsening of malnutrition, right? So this is in gist of all the matters which are seen during that particular situation. CKD leading to with all comorbidities, protein energy wasting is occurring, there is inflammation, there are metabolic derangements, dialysis associated catabolism occurs basically because you are removing so much of blood and then it is exposed to so many membranes, that itself causes inflammation for all these patients, and further leading to your reduction in the nutrition. So now we have understood all these problems. So how much do we really replace? So everybody knows as a rule of thumb that 70% of whatever is required has to be replaced within the first 48 hours. So whenever, usually in the ICU or in other places. Otherwise, if the patient is generally all right, allow oral feeds. There is nothing to stop feeding, because previously there was a thought which was published actually saying that the oral feeds have caused problems for these patients because they are having nausea, vomitings. It's not because of that, it's because you have overfed them initially. That was what was the cause. Later it was identified. So you need to see these particular factors and start doing the nutrition. So how do we really look into this, and how do we calculate? How do we assess that this is the particular percentage we need to give? So this is where the fallacies come into play in CKD. Why? Because edema is there, okay? So then the BMI which you calculate is falsely represented. So whenever there is edema, you do not know the previous dry weight, then it becomes a problem. So for dialysis patients, it's easier because the dry weight is already known to them. right? So once you know the dry weight, you can always calculate what is the requirement of nutrition for them. If it is not so, then it is a problem. If it is obese persons, then how do we calculate? That also is to be remembered. So usually whenever you are taking a calculation, you should maintain the BMI at around 22 to 23. In obese, take it at 25, so that at a particular value you can at least calculate it easily. These are all just to get an approximate values. But of course, if you truly want everything, then it is bioelectric impedance assay or BIA. But the problem with that also is it doesn't calculate your muscle mass. It will only tell you how much fluid is there or how much fat is there. It doesn't truly tell you the muscle mass or how much he has lost the muscle. It doesn't show that this fellow's muscle was so much and it has come down after admission. It doesn't truly so. So if you truly want it, then you have to do an MRI, DEXA scan, or an ultrasound probes which are checking the muscle mass, right? So these are the various methods which were being given, but all these are experimental and truly nobody does it. Just for the muscle mass, will you go and do an MRI for a patient who is already spending so much in an ICU, right? So for that sake only, there is a subjective global assessment score which you all people know. Both subjective things are there, and also there is an objective identifying matters like the triceps fold thickness, then albumin levels, ferritin, and things like that. So you can also assess the muscle function test, basically to see whether that fellow is doing fine or not. What they have found is the hand grip exercise. No, if somebody is unable to move up to 10, that is very easy. These are even available on Amazon also nowadays. Amazon is everywhere. So now when you do that and you get a 10 kgs at discharge, actually it's shown that even in CKD there is a higher mortality rate. And at the end of 1 month, if they reach only up to 15 kgs in the hand grip method, then they have a higher mortality rate. So the mortality occurs within 3 months. So that is the unfortunate part of it. And of course, you have other methods of checking the muscle strength and all that. So that will also give you an idea. The score is obviously from 0 to 60, you need to take it. So if you have to look at the other malnutrition scores, these are all the different malnutrition scores which have already been there. These are all there from a long duration of time. Nutritional risk screening, mini nutrition assessment forms, these are all available very much on the net, so I don't need to really look at it. But I'll tell you, basic thing is, it just tries to recall how much diet that fellow has been taking over a period of time, whether that fellow has developed weight loss, and whether that fellow's weight is alright or not, and the muscle mass is alright or not. But these are all again subjective. We don't have a truly objective method of looking at these particular factors. So that is when these particular global leadership initiative on malnutrition, very glim is the actual way of telling it. Anyway, it is glum or glim, or it is very poor thing, right? So it basically indicates a phenotypic criteria. Phenotypic criteria again is where they are going to see non-volition. Volition is basically intentional, okay? So without intention, if there is a weight loss, if there is a BMI which is less, that is anything below 16 and anything below 19 or 22 to 20, so 25, so things like that, they have classified it. And then there is a reduced muscle mass. Here again they use only MRI and DEXA for that. They don't even use BIA. So it really doesn't fit into our thing at all. So, and one of these criteria should always be there, phenotypic criteria. And etiological criteria is 1 week reduction in food intake. So I didn't eat yesterday, so I can also fall into this play, right? So it is not so, right? So, and inflammation, it can be an acute inflammation or a chronic inflammation. So how do we really assess? It's very difficult. So in general, if you have to see for the protein energy wasting and all that, so the International Society of Renal Disease and Metabolism has classified that this is protein energy wasting. So in patients who are admitted, there is a decreased body store of all these materials. So you should always consider them as malnourished and look into any other features where they are going into severe malnourishment, like cachexia, or going in for a sarcopenia, right? So nutrition supplement, obviously we have already discussed. In 48 hours you get it, preferably enteral rather than parenteral, okay? So if enteral, for a shorter ICU stay and lesser infections is much better, because obviously you are putting a line and that itself can cause more infection for parenteral nutrition. Hence, parenteral nutrition is not to be given in these patients who are having CKDs or an acute kidney injury. Parenteral nutrition, however, is to be given when there is intake is compromised and they are very severely ill and they are dependent on dialysis. So then you can always give it during dialysis. So all these amino acid supplementation, protein supplementation can keep going on. And obviously starting will be with a carbohydrate of 25 to 30% for per kg. The other thing is to use these particular equations, Harris-Benedict equation, but obviously these are also fallacies because edema will mask the picture, right? So when we have no edema or we have a dry weight for that particular individual, it's very easy to calculate. Otherwise, it becomes a problem. And there is something called an indirect calorimetry, which I think sir would have seen, but I have not seen any, where this particular shield or a mask is kept over the patient. This is kept over the patient, and then they will be monitoring the oxygen consumption and they will see how much carbon dioxide is released. So these two things for a non-ventilated patient. For a ventilated patient, they will see how much is the oxygen going into the patient, how much is coming out with the EtCO2, and they will calculate it using that particular formula. So this is supposed to be the best. So once you check with an indirect calorimetry, and then you can identify, and whatever you have calculated, that full amount can be replaced for the patient if he is tolerating. So that is how it is calculated. So nutrition support, obviously when you are calculating everything, so 75% should be the approach for us, because we are doing it in arbitrary manner. We are not exactly calculating using all those particular equations. So that is what it is. So if you are giving hypocaloric, you give it at around 70%. That is what is most important, right? And protein supplements, obviously in CKD it is at a lower level, and once they are on the stage where they require dialysis, it is at a higher level, right? And electrolytes, here again what we already discussed. So look at all the factors, because hyperkalemia, hypokalemia, hypomagnesemia. See, hyperkalemia is not the only thing always seen. So a patient who is having CKD can also have hypokalemia. They can have hypomagnesemia in the ICU settings. So that has to be replaced. So you need to look at the diet which you are giving also. So all the nutritional supplements which we give are very electrolyte poor in dialysis patients. So those we need to look at and adjust it. And when there is hypophosphatemia because of prolonged starvation, you need to replace phosphorus also. And trace elements, nothing much has been really studied in CKD, because we do not know whether it truly helps or not, but however they can be replaced through tablets. So to conclude, basically it's a very difficult thing to take care of the nutrition. So we leave it to you, right? Okay, thank you.